The lady that I'm doing my case study on is a 68-year-old female who came into Wesley Long ED via EMS for hematemesis and nausea. She came in about 4:30 in the afternoon, and she said that she had been vomiting since about 4 o'clock that morning. Um, she when she came in, we went in there, assessed her GI, listened to her bowel sounds, asked her, of course, when the symptoms started, and had she had the coffee ground emesis the whole time, and she said that she had. She also told us that she had been having darker stools, but she said it was because of the iron that she had been taking. Of course, the doctor ordered a occult blood, and she was positive for that. So she was bleeding in her GI tract somewhere, maybe multiple sites. She also had a history of stomach ulcers. So we were kind of thinking that this could be the same thing. Um, she received Zofran 4 milligrams in the ED with us, and she received Protonix 40 milligrams for the stomach acid. The Zofran was for nausea, and vitamin K because of the bleeding. And she needed to clot. Vitamin K is a clotting factor. So, her fluids, we got her an IV started and got her some fluids to help to maintain her blood pressure just in case, because she was bleeding. We didn't want her blood pressure to bottom out. Her electrolytes, um, she her she had a potassium of 2.6. Her glucose was high, but she has diabetes, and that's, kind of normal. Her albumin was low at 2.8, and her BUN and creatinine were elevated, and she has a history of renal disease. We drew a BNP on her, and her BNP was 13,153, which is because of her history of heart failure. Her vital signs throughout her stay with us, and I only had her for about 2.5 hours. Um, her temperature was a little elevated, but everything else was normal. Blood pressure was a little elevated when she came in, but it dropped down to normal for her, which her elevation could have been because of the stress of calling EMS, coming in via EMS, and being back in the emergency room after she had just gotten discharged on Friday, and this was on Sunday when she came back. Um, but her oxygen was, in the high 90s, sometimes 100%, even on 2 liters. She was setting that high. Her perfusion, she was great. She was not mottled. She had good capillary refill. Her hands and extremities were all warm. She had good pulses, which was, kind of a good sign. It was actually a very good sign for us because we didn't know how much she was bleeding. Um, Her assessments that we did, like I said, the GI assessment, listening to her bowel sounds, asking her the questions about when her last bowel movement was, how long she'd been vomiting, how much she had vomited every time she vomited, those kind of questions. Her immune system, her white blood cell count was 17.3, and I'm not sure if this was related to the possible stomach ulcer or if she had an infection going on. Not 100% sure there. I didn't have her long enough to really find out what that was related to. The hemorrhage versus clotting part of this is really interesting because she was on Coumadin um, to, you know, keep everything normal in her body because she has a history of clotting. So her PTT was 85, her PT was 54.7, and her INR was 6.05. She also tested positive for occult blood. So these levels this high clearly mean that she's going to bleed. She has no clotting factors. Um, so the doctor diagnosed her with Coumadin toxicity. Her mobility, we wouldn't let her out of the bed because we didn't want her to get up and drop her blood pressure and her pass out on the floor. But she could move all of her extremities to command. She had control over her head and her trunk. Um, and her body was in complete alignment. She wasn't in too much pain at this time. She didn't ask for any pain medicine and she didn't want any pain medicine. She had a little bit of gastric pain, but we weren't sure if this was from her vomiting for 12 hours or if it was because she had like an ulcer or something. We didn't do much teaching with her because we didn't have her but for a couple of hours. Um, so the procedures, she had an EKG, she went to CT scan, she had an IV placed, and that's about all the procedures that I can think of. Growth and development was not assessed because, like I said, I didn't have her for very long, so we didn't assess that. Our primary concern was her bleeding, actively bleeding. Collaborated with the doctor to let him know that she was having coffee ground emesis and that he needed to see her right away. Also, you know, he told us what needed to be done for her, which was the IV, the fluids, the lab draws, making sure that she got to CT scan and x-ray. We also had to collaborate with CT and x-ray to make sure that they knew that she needed to be on oxygen, she was actively bleeding, and if like her pressure dropped or anything like that, that we need to be made aware immediately. Also had collaboration with the GI doc, to get him in there to assess, what's the next step with her care as far as the GI bleed goes. Nutrition and elimination. She had stress incontinence. She's normally continent at home, but because of the hospital bed and her increased stress level, she was unable to hold her urine, but she was continent of bowel. She was NPO at this time and was going to have an NG tube placed to suction so that she wasn't vomiting everything, but she was getting IV fluids at 125 an hour. I think that we did the best we could to take care of her. We got everything done as fast as we could and was always checking on her, made sure that she was on the cardiac monitor, made sure that she was on frequent vitals and that we were going in and making sure that she was alive and breathing and not just looking at the computer and seeing a blood pressure. Um, Other than that, I don't have much else. Um, I guess that's it.